today I'm joined by someone whose work has really helped push bedside care forward, Matt Ostroff. I first met Matt, gosh, probably when I had just started Care+Wear at the Association for Vascular Access scientific meeting. He is an advanced practice nurse practitioner, founder of the Vascular Access Program at St. Joseph's Health, and now the founder of ClinSpec Solutions, a company focused on advancing clinical practice through innovation and education. Over the year, Matt's work has been recognized nationally and has helped expand what's possible at the bedside across a wide range of patient populations. And I know both personally for me as well as for many others, he served as a mentor, especially in the vascular access space. But really, what stands out most to me is how much of his work is rooted in real clinical need, not just what looks good in theory, but what actually makes a difference in practice. And I think that that kind of speaks volumes to who he is and how he is. So, Matt, I'm really looking forward to our conversation today. Thank you so much for joining me.
Thanks for inviting me. It's a privilege to even share, some of the work because we're all working all around the country, around the world, and to get a chance to kind of share is special.
So why don't we dive right in? You've built a vascular access program that's been recognized in a big way, and you're always a keynote speaker for what seems to be every conference I go to. And now you're also building through your company, ClinSpec Solutions. Every shift in care usually starts with a problem that needs solving. What gap did you see early on that made you feel we need to approach this differently?
That's a great question, and I really appreciate in the introduction you mentioning that I'm not doing things because they're cool, fun, or exciting, but because my patients need it. And when I was thinking about what I really wanted to share and the message I wanted to get across, and I keep trying to say it in so many different ways, is really that I haven't changed anything, or the recognition we're getting is not any different than any other program. I think what's happening at my hospital is that I'm allowed to assess and do the individualized care that each patient actually needs and deserves rather
Mm,
than confined into protocols and just standards. So I
yeah.
feel like I'm not, doing anything amazing. I'm just able to be given the support by my administration to do what each patient actually needs. And because my patients are so complex,
Right.
is why everything has gone like from, way outside of the box because they say, look, if this will help the patient, yes, let's do it. And I think that's really where the recognition comes in for the program. It's not necessarily the work, but it's our patients and being able to say, hey, wait, maybe this approach is better and safely implementing it. So that's kind of like where I'm coming from and my background here.
No, I love that. And I think that's kind of what has always made me appreciate you. And that's the similar kind of thinking that we have here at Care+Wear and how we're approaching design. Because for us, it's, why are you tolerating something a certain way, or why are you doing something a certain way? When you think about things like the patient gown, right? Like people have exposed their backsides in the hospital for years. And it was just something that we said, oh, this is part of the experience. And when you kind of stop and question it, it's like, wait, why the heck is this the experience? Like, how can we eliminate that exposed backside?
Yeah,
Um,
it's this thing with our equity project that we did a few
yeah,
years ago, where I had listened to Dr. Stephanie Pitts mention that it's not right that darker babies are being stuck more because of their skin pigmentation. And then
yeah,
said, why not infrared light? Why not ultrasound? Why is everybody just stuck instead of assessed and said, hey,
right.
look, I can't see your veins, so you get an ultrasound. I can't see
Yeah,
it. You near infrared. Use your problem of tackling, the exposed backside. The joke, right? At the bedside, we're like, well, we're gonna wrap you up, unless you're getting money.
right.
It's not right. But we subject these patients, to these things. Even, ports, for
Yeah,
example. You offer amazing options for patients that are so vulnerable, and then we have these alternatives, like let's say a leg port. well, what do? You can wear a skirt, I guess. You can wear shorts. But if you have an option of being able to unzip, the pants in a certain area, get your treatment and be, leave.
Yeah,
These are ways that we're now taking what we've kind of perfected, right? We kind of know how to access. We have ultrasound, we have navigation equipment. We really do know how to do it. Now we need to make it for the patient, not
right.
just for us. And that's what I love about what you're doing is giving patients dignity. And that's our
Yeah.
job, right?
No, exactly. One thing you kind of talked about that I do think is unique about you all and your team is the how your work spans such a wide range of patients. Like oftentimes you'll meet people that are only doing peds, only doing adults, only doing a certain segment of the population, and you go from everyone, right? And how has that shaped the way you think about care, especially when it comes to balancing consistency? With the fact that, as you said, every patient's needs can look so different.
I am so lucky, I think, to be treating patients from a 360-gram neonate to a 600-pound patient that has morbid obesity, and that challenge of how do I get care when my veins are so deep, or the skin folds. It it helps in so many different ways. The first way it helps, when you're treating neonates, the delicacy of your needlework is what makes it safe in adults to do the more
Hmm.
complex approaches, whether you're going for a low puncture jugular or a brachiocephalic or the axillary in the chest, even PICCs and midlines. It gives you that feel, that touch. And then knowing the different supplies, like that there's a 4 French double lumen 13 centimeter central line for a child, which actually is a 4 French 13 centimeter double lumen midline in an adult.
Yeah,
And when you don't have supplies, I think this came in, probably the biggest highlight that this came into play was COVID.
yeah.
We ran out of supplies. And
Hmm.
most people were like, we're out of supplies. I said, wait a second. We have 5 French triple lumen pediatric central lines. We may not get the high flow rate, but that can be our adult central line. And the
Right.
PIC companies are not selling their 6 French triples. That can be our new triple lumen because we have a triple lumen shortage of the
Hmm.
7 French. So just that knowledge of in and out, simple things like, oh, there's 2 French introducers. That'll help me get. I had to do a posterior tibial arterial catheterization on this patient that just was very complex. I'm like, how do I get down there? Because it's deeper than my radial access line that I wanted to use for it.
Yeah,
And I was able to use a pediatric 1.9 French catheter and get that in there. So it really does expand your just knowledge of what's out there, options, even simple things. We take care of our babies better. We have to admit it. It's
yeah.
a tragedy, but we do.
Right.
Uh, Skincare products like adhesive remover. There are these amazing. I went to Florida. Holly Hess, this wonderful neonatal practitioner, and
Hmm.
she started spraying the dressing and taking it off. And I said, "What is that?" Oh, this is our adhesive remover. And I'm like, oh my God. And I brought that back. And it brings me to another important thing. None of this, none of this is all my ideas, right? I traveled. I went to Florida to watch Holly Hess when I wanted to do NICUs. I
Yeah,
took train to Baltimore to train with Dr. LeDun because I heard he was this, wizard of
yeah.
access. And I would train up there, and I would even have to buy my lunch sometimes. Sometimes he would cover the lunch, but I just watched. And then when I wanted to tunnel and do ports and more advanced stuff, I flew myself to Italy and I watched Dr. Pitteruti and his team. It's you kind of, if you really want to push the boundaries and expand, you also have to make the effort
Yeah.
to train and to earn it. And you don't, my philosophy is don't wait. If you
Right.
wait for your or someone to help you to fund you, you're gonna wait your whole career. You're gonna wait a
Right.
long time. But you know what? It's worth the sacrifice of my coffee or maybe that new jacket that I want to
Yeah.
buy to go and watch these experts and take back and give it to my patients.
Right. No, I love that. An editor's note, by the way, Matt really loves to wear fashionable jackets, so that is a meaningful jacket that he's turning down. But I really love I love that quest for learning, and I very much agree. Um, I took the same approach when we built Care+Wear. Like I saw a problem, but I didn't know jack about trying to solve it, and so wanted to get the right people in the room with me, and that's kind of become our three-pronged approach where we're working with patients, clinicians, and designers on each and every one of our products. Because that's the best way to do it is work with the people that are kind of seeing the problem firsthand and experiencing it and getting their input. But you just brought up a really good point in terms of traveling and learning from the best. I think when you think about you've helped bring more advanced procedures directly to the bedside, to your institution. Do you think that healthcare has historically over-centralized certain types of care? And if so, what are we missing because of that?
So, what I think has happened
Hmm.
is that healthcare has advanced, but healthcare has remained traditional. And what I mean by that is ultrasound changes the risk of central access, where
Mm,
at initially you needed a physician levelly trained person, one to deal with pneumothorax or all the complications that can
right.
happen from this blind just jabbing necks and chests. So
Yeah.
ultrasound really mitigated those risks. Then the question became, well, where are you going to put these catheters? And
Right.
navigation came to the scene. So ultrasound made it safer. Micropuncture and the modified Seldinger approach
Yeah.
made access safer, and navigation made tip placement safer. So when you take those three ingredients
Yeah.
and you bring them back to radiology or the operating room, you have to pause and ask yourself, why are we doing it here now when we don't need fluoroscopy anymore
Right.
for straightforward cases? We don't need this high level of acuity when it's a micropuncture technique that's safely done with ultrasound. And after that, it's tools going either over a wire or through the skin. And that's how we evolved practice here. It was not at all like, I want to do this, I want to help that patient
Yeah.
this way. It was, wait a second. If we're putting in acute dialysis catheters now every day, every
Right.
resident, needle wire dilator catheter. And a tunnel dialysis catheter is simply bringing that catheter under the skin and putting it through the sheath.
Yeah.
Is it this like mystical procedure that's only done in radiology? And that's
Right.
what we did. We broke them down and said, wait, we're already doing this at the bedside. What is the difference? Even today, I'm really excited. I mean, what a day to have a podcast with you. Today
Yeah.
was our 100th port at the bedside.
Oh, wow. Congratulations.
And I get excited. It's not the number 100, but my goal was I will start collecting data and publish retrospectively
Yeah.
at 100. So now I'm excited because now the publication process
Right.
starts. And I do have to note, if you're not publishing and collecting the data, it's just all a good story and you say I can do this, but when you publish it, it becomes peer reviewed and people look at it and
Yeah.
examine, and then it becomes real. When I started that mid-thigh stuff that you had mentioned at the
Right.
beginning, I was trashed at conferences and people said I was a maverick and dangerous, and then I came back in
Yeah.
2018 with my data,
Right.
and the same people that went around saying things came up to me and said, Matt, I want to apologize. You really are approaching this in a safe way and your outcomes show it, but without the outcomes, you're a good story. But back
Right.
to the point, um, when we brought that from Italy, because that's, where I trained on that with Dr.
Yep.
Pitter, it was a PICC line, and it was a PICC line with a pocket. And the funniest part of it was my biggest concern and hesitation to do it was I wanted it to look good cosmetically. I wanted to be able to suture well.
Right.
And that's a skill, that we're normally trained in. So that's something I practiced over and over and over and over. And so that's how we've expanded practice. Not what can we do, but what is the challenge? Why are we not doing it at the
Right.
bedside? And is it safe? The real factor is not the procedure, it's the patient.
Yeah.
Can they lay down flat If they can't lay down flat, well, then, the jugular approach or the chest is probably not going to be your first choice. So you can
Right.
do femoral. Oh, well, how can we make the femoral safer? Maybe get it out of the inguinal crease and put it, in the thigh area. That's a way to do that. And we introduced using a tunneled femoral dialysis catheter
Hmm.
instead of a acute one, just to prevent infection risk, showing the
Right.
doctors that, look, I know you think tunneling is a big deal, but it's the same as putting in an acute
Yeah.
catheter, an extra step, but we could have a lower risk of infection.
Right.
Things like that. Just yesterday we had a patient, they wanted a dialysis catheter tunneled.
Hmm.
And every time we laid her back, she would vomit.
Oh,
So I said,
geez.
we'll come back tomorrow after you give her
Yeah.
some Reglan and some medicine. We put her back, she vomited. So I called the nephrologist and I said, look, she needs dialysis.
Right.
Let's do a femoral approach, get whatever is going on under control, and then replace it. So bridging, coming
Yeah.
up, having the vision to say, maybe I can't do what you want today, but I
Right.
can give you this, and then we can get what you want, tomorrow or the next
Yeah.
day. I'm thinking in steps rather than just the finish line, right?
Right. I was going to say it's like the baby steps or the marathon approach of realizing that you don't need to get it all done in 10 seconds. It's what's best for them and how can you kind of get them there. Um, all right. So to your point, you're now viewed as one of the experts in vascular access in particular. If you think about vascular access today, where do you see the biggest disconnect between what's possible and what's actually happening in practice?
The biggest disconnect that I see is both in administration
Hmm.
and in clinical. I see the disconnect in administration as just not having the ability or the experiences to see
Yeah.
what is possible and to see that it can be done safely. That's the challenge that I see with administration. And without that understanding and knowledge, the support for advancement will not be there until they understand that it can be low risk and very safely performed. The
Right.
disconnect and challenge I see on the clinical side is that if we really want to up the game and we want to
Hmm.
be these, vascular experts, we've got to continue with education. We need
Yeah.
to go further. We need to go for our master's or for our doctoral degree. We need to get our vascular access board certification for our entire team. And it doesn't have to be everybody, but a mixed team, a multidisciplinary team of all different, I don't even want to call it levels because sticking wise, the skill's the same.
Right.
Knowledge wise, and looking at things from different viewpoints is what makes it work for
Yeah.
patients. You can't only look one way.
Right.
And that's where I see that disconnect. And I believe that if we bring the education on the team even further and higher to show them we're committed, that it will make that administration then see what we're seeing and give the support and then make a really beautiful, mesh between the two.
No, I love that. And I think it's that, I mean, you've been harping on this without necessarily saying it, but that desire to improve and continually innovate, I think it's something that is at the heart and soul of what we're doing at Care+Wear with, like with our pick covers, for example, we've changed the mesh window, we've added a silicone grip. How do you always be improving? So I think one question that's super important, you've decided that you don't just want to work directly in clinical care, but you're now also building an incredible new company, ClinSpec Solutions. What's one assumption in the space that you hope gets challenged or redefined?
So this has been the most fascinating journey, and I have to give 1,000% credit to a man named Dago Salinas. He is the founder and CEO of the AI company and the
Hmm.
immersive reality company that we're working on. He was trained in the Navy to do pick lines. They
Wow.
showed him a couple, and then he was out there doing it.
Yeah.
And he said it was uncomfortable, it was scary, it was not the way to learn. So anyway, 20, 4 years later, he retires from the Navy. He could, no pun on words, but sail off into the sunset.
Yeah.
But he wanted to improve care. He wanted to do what you're doing, what I'm doing clinically. And he said, we can make this better. He saw the military trainings with simulation and virtual reality, and he created a pick and a midline virtual reality training.
Yeah.
And he sent me a headset. And I am getting old now, so I'm like 40, 48. And I said, you know what? I want to check this out with my daughter. She's
Mm.
18 and going to nursing school now. If
Yeah.
she thinks this is cool, it's her generation that we're
Right.
trying to change. So
Yeah.
anyway, we put it on, we got into the environment, and we were blown away. And Dago called me a couple days later and said, do you want to partner with me on this? And I said, Dago, I have been waiting my entire career to find someone that would get behind what I want to share
Yeah.
and make this able to be dispersed globally in an immersive way, a way that you can be in, Japan and put
Right.
on a headset and work together at a patient's bedside virtually,
Yeah.
train, together. And that's where we started, like our brains just started exploding. We went from just virtual reality to developing mixed reality, which is an incredible training where you're doing the same thing. You're using a vein board, an ultrasound,
Hmm.
and now there's a patient there that interacts with you to give you that reality.
Right.
It's called reality, to give you that realistic, scenario. We created in the metaverse an institute where you can go and train, and it's just like you and me right
Yeah.
now, but I can make these objects appear, a needle, a guide wire, an introducer, make them big, let you really look at them and digest it. It's called a flipped classroom, where
Mm.
we're able to make it just so much more interactive than PowerPoint, and where you can feel and touch things. And then even bringing in like video screens, where we just recently went to Texas at a cadaver lab and
Yeah.
filmed every procedure you can imagine, from phlebotomy to ports, from prone even access during COVID,
Yeah.
everything. And now we put it into these immersive videos where you can actually be inside the body looking at these catheters going through and seeing, when we describe the left-sided approach, we're like, oh, it has to cross the mediastinum. So we're
Yeah.
like, oh, okay. Well, when you watch the catheter do this,
Right.
it's we dissected open the right atrium to show you where these catheters should sit when they're in the upper third and things like
Yeah.
that. So anyway, what we've developed, you're right, is kind of my next stage in life, and
Yeah.
it's giving back, just like you're giving back to the patients. I
Yeah.
want to give back to the clinicians, and by giving back to the clinicians and teaching, it's going to give back to the patients. And I just got a contract from Springer for the second edition of my book, so
Amazing.
we're going to be expanding another 20 chapters in my complex clinical challenge book, and that's kind of, I hope, my next journey is sharing.
Yeah.
Uh,
Well, you're so good at it, so I think it's going to be incredible. So I've got a couple quick fire questions for you. So I guess if you weren't in healthcare, what do you think you would be doing?
Teaching
Teaching. That I was going to
kids,
guess
teaching
that, but
kids.
teaching kids, love that.
Yeah.
Coffee or tea?
Now coffee that I'm older.
Yeah. What is a book besides your own? Because obviously everyone should go out and get Matt's book. But what's a book that you've been reading recently or have read in the last year that you really like?
I can't say the last year, but I'm going to
Yeah.
tell you the that influenced me the most, and
Yeah.
that's the way of the peaceful warrior, because I
Mm,
believe we need to enter these situations with patience, with complete calmness and preparation, and execute what we're going to do. Not try, but
yeah.
execute what we're going to do.
Love that. What's one piece of advice you would give to new clinicians entering the space?
Keep your eyes open, your ears open, and find that person that you want to learn from, and then find the next person, because nobody is the expert. We all do everything a little different.
Yeah.
Keep You're never at the top of the mountain. Never.
Yeah.
Always listen and learn from that person that you don't think you're going to learn from. You're
Right.
going to find thing and go, "Oh my God, I didn't know you could do that."
Yeah, exactly. And then lastly, this is the most obvious answer, but what is your favorite brand for your patients and your clinicians?
Care+Wear.
Love that. Didn't even have to pay him to say that, guys. Perfect. Well, Matt, this has been amazing. Thank you so much for doing this with us. It's such a privilege and honor to get to kind of learn more and share your story with everyone listening, and excited to see you soon.
Yeah, I will see you soon. Thanks for having me.